Thank you, Dr. Saad, for gathering all of us around you. I'm speaking as an anesthetist who attended many lectures through the panelists of the Mega Online education. And by the name of all anesthetists all over the world, we thanks your efforts for gathering all the anesthetists around the world in one time a day, twice or three times a day, 3 times a month, for taking fruitful educational supports from your side. Fortunately, today we'll speak about the Dr. Ahmed Taha, which is eminent in regional anesthesia, and he is a consultant of anesthesia in Abu Dhabi. And Dr. Ahmed is practicing anesthesia almost more than 20 years since he finished his training in anesthesia in 2003. During these years, Dr. Ahmed also is an active in education and research. His qualification is a master's degree of anesthesia and a PhD of anesthesia in 2002 and 2007, respectively, from the Faculty of Medicine, Ain Shams University in Egypt. His passion in regional anesthesia led him to research on this field, and he was able to publish some original articles, including description of many new blocks techniques. Dr. Ahmed has an enthusiasm about education that led him to create a YouTube channel that is watched by thousands of viewers. Additionally, he is regular participant as a faculty in major workshops in the region of the Middle East. Thank you, and the time is yours, Dr. Ahmed.
Thank you, Dr. Talat, so much, and inshallah, I hope this today will be a very good lecture, inshallah. Bismillah ar-Rahim. Today, inshallah, we'll talk about the blocks in a workshop for abdominal blocks. As you know, that blocks is very important for pain control because it's the quality of pain control as well as minimizing the side effect of narcotic. However, in the abdomen, we have additional factors that make the blocks are necessary in sometimes. First is that we know that abdominal incisions may affect the respiratory mechanic. A high percentage of abdominal surgery resulted in chronic pain. And many of procedures in the abdomen result in DVT. So early ambulation is important, and so pain control is very important to achieve such thing. We have in limb blocks that we have the nerve is big, and we can see it. And as you can see, we can inject local anesthetic around the nerve, what is known as perineural injection. However, and the trunk innervation are very small, and usually we cannot visualize it by ultrasound. And so instead of perineural injection, we do one type of injection called interfascial injection. In this interfascial injection, we are determining the fascial plane where the nerve running and place the local anesthetic there, where the local anesthetic spread to this nerve. So the key of success of this technique is that first is accurate fascial planes identification, and inshallah in this workshop will show many of these fascial planes. And second is the volume of local anesthetic. The higher is the volume, the high success. Fortunately, this block work with very low concentration of local anesthetic. Even 0.15 norepinephrine or ropivacaine is very effective. And sometimes I add DEXA to prolong this duration of analgesia. The block distribution of this local anesthetic is not constant in every patient, and so most of these blocks are used as analgesia. However, in some selective cases, it can be used as anesthesia. I'll show 1 or 2 slides regarding this. The abdominal innervation is divided in 2 categories: the visceral innervation, which is innervated by the sympathetic or autonomic, and the abdomen is entirely sympathetic, and the pelvis is sympathetic and parasympathetic. The good point here that is almost all organs of the upper abdomen is supplied by celiac plexus. And so if you block, and celiac plexus supplied by 5 to 9, T to 5 to 9. So if you block these segments, you block the spleen, the pancreas, the liver, the stomach, and gallbladder, and even the first part of duodenum. So all this visceral innervation can be blocked if you block segment from 2, 5 to 9. But the abdominal wall anteriorly and posteriorly is supplied by somatic nerve. Anteriorly, there's two sets of nerves supplied the abdominal wall. First, the intercostal nerves, which is supplied the upper part of the abdomen, and the subcostal ilioinguinal epigastric supplying this blue region, which is the inguinal region. This region is supplied by these nerves, 3 nerves. But the upper part of the abdomen is supplied by the intercostal nerves, T7 to 11. The T7 to 11 nerves is running similar course to the typical intercostal nerve. Let's go from paravertebral space, then giving lateral branch at the mid-axillary level, then end as anterior branch. The only difference that they are crossing the costal margin to the abdomen. This is the only difference between typical and lower typical intercostal nerve. When they come in the abdomen, all of them running superficial to this muscle, which is known as transversus abdominis muscle. The upper part in this region, which is, we call it epigastric region or the subcostal region. In this region, the nerves, the transversus abdominis muscle is overlaid only by the rectus abdominis. And this fascial plane known as the rectus or subcostal plane, where the rectus abdominis overlying the transversus abdominis. While the lower nerves, when they exit the costal margin, they find themselves between transversus abdominis deep and internal oblique superficially in this plane, what is known as a tap plane, between the intercostal oblique and internal oblique and transversus abdominis. But all nerves of the intercostal nerves end inside the rectus muscle at the anterior branch. And this anterior branch here supply the entire rectus muscle and the skin overlying. Note that the rectus muscle is a huge muscle. It's not a simple muscle. It's a very broad muscle. And so most of surgery and many procedures can be performed transrectal. And so if you anesthetize it, you anesthetize a high percentage of the abdomen. The lower intercostal nerves, the lower part of the abdomen and pelvis where cesarean and inguinal hernias performed are supplied by the 3 nerves, subcostal, ilioinguinal, and iliohypogastric nerve. These 3 nerves have similar course. They started anterior to the quadratus lumborum muscle. So they run anterior to quadratus lumborum muscle. This is the quadratus lumborum in the cut section, and this is the transverse process. The nerves running in this fascial plane anterior to the quadratus lumborum. In the lateral view, this is the lateral view of quadratus lumborum, as inshallah we'll see now. The quadratus lumborum, the nerves running here. This is the psoas muscle, and the nerves running here. After they leave the quadratus lumborum, the nerves running in a small fascial plane here. This is called the transversalis plane, which lie between the transversus abdominis medially and quadratus lumborum laterally. Actually, this injection in this fascial plane is considered as quadratus lumborum 1 block, but some people name it as transversalis plane. Then the nerves running in the transversus abdominis. So the nerve coming from here and going into transversus abdominis plane. At the end of the thorax, you find that the transversus abdominis, the nerve is only lying super deep, just deep to the external oblique. The internal oblique and its fleshy part end in the abdomen, at the lower abdomen before the external oblique. So the nerves lying between these 2 muscles in the very low part of the abdomen. Now we are going to the posterior abdominal wall. The posterior abdominal wall is supplied by the dorsal root, and this is the dorsal root on the right. And this nerve divided into 3 branches: lateral nerve, intermediate nerve, and the median nerve. All of the 3 branches running superficial, just superficial to the transverse process. So a very simple injection of local anesthetic in this fascial plane, just between the muscle and the transverse process, will block these nerves, which is the dorsal root. And this is what we call erect spiny block. However, there is some studies showing that the local anesthetic may spread medially and go inside the epidural space, and giving visceral analgesia and giving anterior wall analgesia. And this erect spiny block is not only in the abdomen, it can be used also in the thorax. And in some cases, some people or some articles are published that can be used even in shoulder surgery. It can, as this is a cut section that you can find erect spiny and this transverse process. In the longitudinal section, it appears like this: the erect spiny muscle longitudinally, and this is the transverse process. In the thorax, it can be used instead of the paravertebral block. In the paravertebral block, we inject local anesthetic between the costotransverse ligament and the pleura in this area. But in erect spiny, we inject between the transversus process and the erect spiny muscle. So local anesthetic, it is relatively safer, and in some article, it can make the same effect. Now, the important question, which block we perform, it depends on the site of the surgery. As we said in the region 1, which is epigastric region at the ventral hernia, that we can use only subcostal block. If the surgery site at the region 2, which is umbilical region, in this block, we can give simply rectus abdominis block. If the surgery in this triangle or this area 3, so in this area, we need the lateral cutaneous branch to be blocked, so we do tap block as posterior as possible. In the area 4, the inguinal region, that we can use one of the quadriceps lumborum block or transversalis block or the ilioinguinal iliohypogastric block. This region is usually used for CS, oblique inguinal hernia, graft, iliac graft taking. So in this case, we give one of these block. And lastly, in the back surgery and spine surgery, we can give the erect spinals. But not one of all of these blocks does not block the viscera, the abdominal viscera. The abdominal viscera to be blocked, it needs a paravertebral block. So if the surgery above the umbilicus, paravertebral block will give additional anesthesia to the internal organ. Also, quadriceps lumborum in the pelvic region, it can, some studies show it can spread to epidural space and give analgesia to the uterus itself. So it's commonly used for the cesarean section. And take care in midline incisions, that's may need bilateral block, because in the midline you need to block the right side and left side. Also in laparoscopic surgeries, there's multiple ports, and each port has to be, you have to calculate which port, how to block each one. So there is multiple blocks for the midline incision and for laparoscopic surgery. The block timing, just I want to give one note here, important, that is note that is after anterior blocks, after the surgery, you cannot do tap or rectus or subcostal, because the tissue disruption and gases, air inside the abdomen will make the block impossible. So if you want to make one of these blocks, you have to do it before surgery. Also in paravertebral and erect spine, you have to position the patient. This is not easy to be performed after induction, so you have to do it before surgery. If the block is multiple blocks in the anterior wall and you don't want patient to be discomfort, you can delay to after induction, but not after surgery. In one situation in cesarean section, there are many prefer to do the block after end of the surgery. So they do QL, give the patient spinal after the delivery, and the patient shifted to the post-operative unit. They give her the block of QL or something like this. But QL really works longer than the ilioinguinal iliohypogastric block. So it's very recommended in this case. These blocks are very effective. In these two selected cases, it can be used as anaesthesia, but this is not the routine. This is not my routine, and this is not the routine. But just I want to show it to you how effective is the block. This is a case of this lap cholecystectomy, and we give this lady a paravertebral block bilaterally at the level of the T7, and it can be managed very simply by this block. But this is not the routine. Okay, she's sedated, and after surgery she can be ambulated immediately because paravertebral block does not block the lower limb. Similarly, in this case, it's a huge omentum hernia, ventral hernia, and this patient take bilateral rectus sheath block, and it's done by harmonica. This is not that painful, so we add some sedation and it was okay. So these blocks are very effective, and I consider it is very important to be given to patient with the general anesthesia, whatever technique you give, because it's long acting and it's not like epidural does not need care. So we give this injection and the patient will go home. And some hospitals, they have the liposomal bupivacaine, so it can be give analgesia for 4 or 5 days. So this is a background of the anatomical background of these techniques. We'll now go for workshop and see how to do these blocks on the one of my of the patients. Okay, so I'll close this account and خلاص انا هعكس بقى الكاميرا عشان ايه نبتدي. بسم الله الرحمن الرحيم. ابتدي على جنب كده. اوكي 20 دقيقة كلها ايه 20 دقيقة كده الصورة واضحة دكتور سعد صح؟
تمام تمام
طيب يلا اوكي نقلنا على جنب كده. الصورة واضحة دكتور سعد صح؟
تمام
اوكي هتبعت علينا عشان ابراهيم جو روح جوه عشان تبقى قريب على الكاستين. اوكي. First, we'll start by transverse erector spiny block. Then we'll go for quadratus lumborum block. Then we'll go transversalis block. Then we'll go anterior. So we'll start with the posterior blocks. In the posterior erector spiny, it needs positioning with the patient. Usually, if you do it unilaterally, you do it in the lateral position. But if you do it bilaterally, you can do it in prone position. And also, if you do it for spine surgery, you can do it after positioning of the patient. So do induction as normal, then do the block after induction. The erector spiny block, as we said, this is the erector spiny muscle. You can see it. This is the muscle, bulky muscle here. This is the erector spiny muscle. And by the way, the more criteria you know about the muscle, the more successful block, because in some patients, identification of muscles of ultrasound may be difficult. So if one criteria doesn't work, it may be help another criteria. So this is the erector spiny muscle. It's a big muscle, and it lies directly above the transverse process. So what we'll do, we'll try to identify the transverse process, and we'll inject between the transverse process and the muscle. Let's see. So we put the transverse process. This is now the probe is placed axially. This will be on the right part, in the left part of the screen. This is lateral, and this is medial. We try to identify, look by here, Nishan. We try to identify the transverse process. This is the transverse process here, this one. As you can see, this is the SAP, the superior articular process. And this is the transverse process. So simply, this is the erector spiny muscle. So in this view, if you don't find the transverse process, just move the probe up and down to find them, concentrate tension. So you just make it a slight tilt to identify the probe up and down to identify the transverse process. As you can see, this is the transverse process here. It's a bony part. And this is the articular process. And if you inject here, the local anesthetic, this is the erector spiny block. Some physicians want to block this block at many levels. So this transverse process here, one here, one here. So they do it in vertical approach. So they put the probe vertically, want to identify the transverse process. And this is the tip of transverse process here and here. So you go with the needle, inject here, then redirect and inject here, and redirect and inject here. Some prefer this technique to block many levels. However, this also describes. Mainly, I use this block for the spine surgery, but I don't use it for abdomen. However, a lot of researchers describe it can be effective in the abdominal surgery. So this is the first one, the erector spiny block. We'll go to the next muscles, which is the quadratus lumborum. Quadratus lumborum lying deep to this muscle, so and slightly lateral. So we put the ultrasound probe here, and if you put the ultrasound probe, it will be second layer here. So let's go and see first criteria of this quadratus lumborum. The probe, this will be oriented caudally, and this will be cephalic. So we put it at the end of the muscle here, and want to see the layers of the muscle. So this is the first layer, as you can see here. This is the erector spiny block, and the second one deep, this is the transversus abdominis muscle. I'm sorry, this is a quadratus lumborum muscle. This one. If you go up with it, you find it attached to first last rib, and if you go down, you find it attached to the, I'm sorry, you find it attached to the iliac crest. So this is the quadratus lumborum. It's very variable size between patients, so that's why you need a lot of criteria to identify it. After you get this, you tilt the probe and get it in the axial section. So first identify it in the longitudinal section, then tilt the probe to identify it in the lateral or axial section. Okay, let's see this on the screen here. So this is a muscle. We concentrate with the muscle here, then we'll go tilt, 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 and we find it here, as you can see, attaches to the first rib, to the transverse process. So this is the transverse process, and this is quadratus lumborum. There is many kind of injection of quadratus lumborum. For cesarean, Dr. Blanco himself inject posteriorly to the muscle. So injecting this fascial plane. I usually use it for the iliac graft crest, so I inject lateral to the muscle, lateral to the muscle. As you can see here, this is a muscle, that quadratus lumborum muscle, and it is a variable size between patients. So this is the quadratus lumborum muscle. So I hope this is clear. I'll repeat this again before we change the probe size. So we have in this area 2 blocks, the erect spiny block, that we can do it in horizontal way, like here, erect spiny. We move the ultrasound till we identify the transverse process. This is a transverse process. The medial to superficial to transverse process is erect spiny. Lateral to transverse process, this is the quadratus lumborum. And deep to quadratus lumborum, the transverse process, but you cannot see it now, it will be the psoas muscle. Okay, so this is anatomy, sonographic anatomy. If you want to do erect spiny block, you can inject local anesthetic here. If you want to do quadratus lumborum block, you can inject local anesthetic here, or inside the muscle, or between the muscle and psoas muscle. So there is many, or lateral, or lateral. Take care, that is in quadratus lumborum anatomy, in the superior part, it's deep to the kidney, is deep to it. So if you take a deep breath, you'll find the kidney moving here. See, this structure is the kidney. ابراهيم خد نفس جامد يا ابراهيم. You can see the kidney. Okay, so this is the quadratus lumborum here, the second layer deep to the erect spiny. You'll find quadratus lumborum. Above it's attached to last rib. Below it's attached to the iliac crest here. And if you go medially, the muscle attached to the transverse process. Look to this fascial layer, look to this fascial plane. If you go medially, I move the probe medially. Show it when I move it medially. So if you move it medially, just like this, you can see, identify that transverse process. Look, go back and shine here to the image. So this is a quadratus lumborum. If you go slightly medial, you can see the tip of transverse process. So this is so for sure, this muscle is quadratus lumborum. We'll go now to the anterior blocks to identify the rest of the muscles. تعال ابراهيم على ظهرك. Okay. Now we have from here the transversus abdominis, all the nerves now run superficial to transversus abdominis. Transversus abdominis flesh stop at the level of the mid-axial line. It does not contain the fleshy part, does not accept it usually posteriorly. But the internal, external oblique and the internal oblique goes beyond the axial line. So when the transversus abdominis end here, it leaves a fascial plane between it and quadratus lumborum, and this fascial plane known as transversalis fascial plane, which is actually quadratus lumborum 1 block. So if you put the ultrasound probe like this is the last rib here, and this is the iliac crest. If you put it in the between, as you can see, this is the external intercostal, external oblique. This is the internal oblique, and this is the transversus abdominis. If you go posteriorly, the transversus abdominis end at this point. And so this fascia is the transversalis fascia. So usually this end by finding the quadratus lumborum muscle. So this is the quadratus lumborum muscle. So in this fascial plane, even you can find thickening here, which indicating the nerve is running in this area of the fascia. So if the block of the inserted in this fascial plane, connecting the end transversus abdominis muscle and the quadratus lumborum muscle, this fascial plane is called transversalis plane. And injection in this plane is actually a transverse quadratus lumborum block 1, and it gives a very good anesthesia for the pelvic region. So if you do cesarean, if you go in iliac graft, if you take oblique inguinal hernia or something, this block is very good. But take care in this area to not be confused with the extrapyramidal or the fat of the abdomen. Look in this area, this is not a muscle layer. This is an extraperitoneal fat. So take care. This is extraperitoneal fat to not be misdiagnosed as a muscle layer. As you can see here, there is no fat here. It started almost in the mid-axillary. Then here, the fat with extraperitoneal fat become thicker. Then here, the muscle end. So this is a transversal abdominis, not this. So this one, same one, is the transversal abdominis. Okay. Now we'll go the nerves are running in the TAP plane or transversus abdominis plane. How we can identify this plane? This plane is running between the deep muscle of transversus abdominis and the internal or the internal oblique. The point is, in some patient, in obese patient, you may find inside fatty layers and sheets, making the difficult of identifying the 3 layer. And this friend Ibrahim, it's very clear, 3 layer, 1, 2, 3. So this is a transversus abdominis, and we can inject between the internal oblique and the transversus abdominis very easy. But in morbid, especially in morbid obese, in morbid obese, maybe it's very difficult to identify this fascia layer. So the trick here, that is the internal oblique is the thickest muscle medially. So if you go medially, you'll find that this is the thickest muscle of them is the internal oblique. So we inject deep to the thickest muscle. If you go posteriorly, the difference between the internal oblique and the external oblique become less. So here, look, the two muscles almost look the same. So this the external oblique, internal oblique, they almost look the same posteriorly. But if you go anteriorly, you'll find that is the internal oblique, it's so big. It's bigger than the both of them. So bigger than transversus abdominis and bigger than the external oblique. So in this way, go closer, Michelle. So in this way, as you can see, we can identify the internal oblique is the thickest thick muscle medially. But posteriorly, as you can see here, this will not be, this difference in thickness will not be there. And automatically, once this is the internal oblique, so this is the transversus abdominis. And if you go posteriorly, you will find transversus abdominis at the mid-axillary line here. And leaving this fascia plane, which is identified as the transversalis fascia plane. Okay, I hope this is very clear. Now we go to one of the very important block, which is the midline blocks, or the surgery of the midline. That is rectus abdominis and subcostal. As we said here, that nerves come from abdomen. Nerves coming from intercostal nerves cross deep to the costal margin. When it becomes between the transversus abdominis muscle, and in this area, only the rectus abdominis is overlapping. So only 2 layers of muscle here. Down, the transversus abdominis will become not fleshy, and so you cannot find it. So it will start to be replaced as a sheath. So up, you'll find the fleshy part of the transversus abdominis, especially if you tilt the probe laterally. So if you put the probe like this and tilt it laterally, the fleshy part, the transversus abdominis, will be overlapped with the rectus abdominis, and nerves running between this. This triangle or this block, we call this subcostal block. So as you can see here, we'll show it now in the ultrasound. We'll place the ultrasound probe here, parallel to the costal margin, and we tilt it anteriorly inside. So this is the picture. As you can see, the superficial muscle here is the rectus abdominis, and the lower muscle here, transversus abdominis. If you inject local anesthetic between these 2 muscles, this is called subcostal block. As you can see, the transversus abdominis muscle here is a fleshy part, is a flesh. But this fleshy part will be no longer flesh posteriorly. Look here. Look, it's not become, look to this area, it become, the fleshy part becomes shorter and shorter and shorter and shorter, and now it becomes a sheath. So this transversus abdominis plane, the fleshy part here, it becomes a sheath here. So we still inject between the muscle and the sheath, or as we can inject here between the muscle and the muscle, that between the 2 muscles, we'll inject between the muscle and sheath. Also, if you go lateral like this, you'll find that this subcostal plane continue with the TAP plane. So they are actually one plane, but we inject one plane. But we inject here to get more anesthesia or more success rate to block these nerves, innervation. But all this area is one. So if you inject, so they are all actually connected, but you need very large amount of local anesthetic to spread all that. So to get a high success, we specialized our injection according to the site of procedure. So as I will show you now, combination again. So this is costal plan. This is the rectus abdominis, and this is the transversus abdominis, and this is the subcostal. If you go laterally, you will find it lateral like this. You will find it continuous as the, look, it will continue as a tab block. So this is the tab plane. You see this? If you go up, it will become subcostal. If you go down, it becomes a tab. So they are actually connected together. Similarly, the subcostal, if you go posteriorly or inferiorly, it becomes continuous like rectus abdominis muscle. Rectus abdominis muscle is a huge muscle, and it supplies, this is the nipple line. It's almost actually to the nipple line, connected from the ribs up to the pubic bone down. And the entire muscle is entirely innervated by the anterior branch. The anterior branch pierces the muscle, supplies the muscle, and pierces the muscle. Then it supplies the whole skin overlying the muscle. So if you give the rectus sheath block, you are supposed to block all this area, skin and muscle. So this is very good in midline incision or in ventral hernia. You don't need then rectus sheath. Let's have some criteria about the rectus muscle who can identify, because identification of rectus muscle in morbid obesity is not easy. Let's have some criteria. Rectus muscle below the umbilicus, the two recti are attached in the midline to each other. Look here. This is the right rectus. I'm sorry, this is the left rectus. And this is the right rectus. As you can see, they are attached. But above the midline, there is a gap between the two muscles. Look. Rectus, rectus. And there is what you call it, a diamond-shaped fatty layer always below. This is this one. You see this fatty layer? It's always below the midline. In this area, as you go down, you find the same fatty layer. Okay? Rectus muscle, as we said, extend laterally till, this is the abdominal organ, by the way. And so this is very important. As you can see, the abdominal viscera is very close. So never inject or insert the needle without seeing the tip. So not harm any abdominal organs, okay? So if you want to insert the needle, you have to see the tip. It's very risky to pass the needle and you don't see where is the needle, and you may injure some structure. Therefore, also being we use the interfacial injection, not perineal injection, you can use simply simple spinal needle. And if you cannot see accurately, or the needle is not clear, you can use big needle, 18 gauge or something, to achieve good resolution of the needle, to not advance the needle tip without seeing, because this is a very risky. Abdominal structure is very close here. So as we see, that if you go laterally, the muscle extends to here. So this point, almost the nipple line, you can find all this area is the transversus, is the rectus abdominis muscle. The rectus abdominis has another criteria, very good criteria, that it is below the umbilicus. You can identify the inferior epigastric vessels, and this is a good landmark for the muscle. So let's see here if you can see.
Dr. Ahmed, you have 10 minutes. 10 minutes.
10 minutes. Yeah. Okay.
Yeah, thank you.
Okay, as you can see here, look, this is the inferior gastric vessel, and this can show it's anastomosed with the superior vessel, but actually the superior is small. You cannot see it in most of time. So this is the inferior gastric vessel, and this is identified the fascial plane. So the last thing you can find here in the rectus abdominis, that is very separated from the tendinous arch at the side of the six pack. We call it six packs. So at the six packs, you find this muscle attached to the lower lower sheath. So look at this point, the muscle attached with the sheath. So this called, that's what we identified externally as circumflex. So this is a rectus abdominis muscle. And if you want to block it, just identify the rectus sheath and we inject between the muscle and its posterior sheath. So we inject in this fascial plate. So this is the rectus abdominis. In some situation, if you want to do, for example, midline incision, so I prefer to do vertical block like this. So I want to block all this area. If the patient is awake and I don't want to do multiple injection, I do here, then I come back and do here, then I come back and do here. We can do a technique that we move the probe, not the needle. So we insert the needle from here, infiltrate the whole amount, look anesthetic here. Then we put the probe below the needle and redirect the needle. If the patient is awake and you don't want to move multiple injections and discomfort for him, so this will be a very good point. As we said, block of the anterior abdomen should be before surgery, because usually tissue disruption after surgery will make these blocks impossible. This block will become impossible if you do it after surgery. One important block here that we called it the ilioinguinal iliohypogastric. The ilioinguinal hypogastric running like this. So we put the ultrasound like this. We put the ultrasound oblique like this. However, you can start tilting the probe or rotating the probe until you find a clear picture of the ilioinguinal and iliohypogastric. As we will see now. Yeah, I'm very lucky. I can find it very easily. Look at this here. It looks like a Zorro opening. You see this one? This is some people call Zorro sign. That is a gap between the anterior abdominal muscle. You can tilt the probe, rotate the probe until you find a big good picture. As you can see here, this is the nerve, and you can follow the nerve proximal as much as you want to get this nerve and to block it as proximal as you can. As you can, this is what we know as Zorro sign. The two gaps of eyes of Zorro. So this is the ilioinguinal and iliohypogastric nerve. As come here in Shen, in the upper part of the abdomen, it lies normally in the tap plane between the transverse abdominis and the external oblique. But if you go down, there will no be longer internal oblique. So the nerve may be fine. There is no 3-layer arrangement of the muscle will not be exist if you go down deep to the inguinal region. One more thing that I want to show to you, that is umbilical, the cord block. Put attention here. Okay, this is this is bunch of vessel here. This is the cord, spermatic cord. As you can see, it can transmit hernia. And if you do hernia with this area, if you do hernia alone without general anesthesia, it's better to do some infiltration here. Usually this is done by surgeon. However, you can do it because some surgeon doesn't give time. So you can just inject local anesthetic around the spermatic cord here to give anesthesia or analgesia to the structures running here. So when the surgeon start to pull this structure, the patient minimize the discomfort. But take care, there's many vessels here and we don't injure them. So it's very careful to make this is the inferior gastric before joining the external ileum. So it's be very careful before you inserting the needle. In general, before inserting the needle, you have to activate the color Doppler to see what is the vessel in the base of the needle. Just activate it and see where the vessel, and then you can switch it off, because usually the color Doppler image is worse than the normal 2D. So the 2D, the picture is better. In the last minutes, I want to show you the quadratus lumborum in the supine position. In some situation, as we said in cesarean, you may need to give the quadratus lumborum in the supine position, but this is not the classic. In classic, if you want to do quadratus lumborum, you do it in lateral position, because when you see the muscle from posteriorly, the muscle is more superficial, as we've shown. So it's just 2 or 3 centimeter depth. But if you see it from lateral, the muscle is actually deep. Identification is difficult than that from the posterior. However, if the patient cannot be, if you do bilateral block and the patient have a spinal anesthesia like in cesarean, so in this situation, some prefer to do it in the lateral, in the spine position, putting the ultrasound probe here and try to identify the muscle as well, show it to you. Usually this probe will not work, so we will use the curved probe. Take care when you use a curved probe, the picture will be totally changed. So that's why I usually fix the probe I do with the block. So in average patient, so in average weight patient, I use a curved probe for erectus spinae and quadratus lumborum block. And even paravertebral block, I use a curved probe. In the same patient, I use a linear probe for the tap and rectus sheath and subcostal and transversalis block. Except that in morbid obese, I can use for rectus abdominis curved probe also. So usually I use the curved probe for posterior block, including the lateral quadratus lumborum block. We will do alcohol here, then we'll put the ultrasound probe, and let's see this mark, which will be the left, will be cephalic or anterior, and the other side, which will be the right, will be posterior. Look, this is the 3 abdominal muscles, 1, 2, 3, and this is the extraperitoneal fat, as I told you. At the end of them, you will find a muscle that is darker in color than the surrounding muscle. This is the quadratus lumborum, and looks like the Google location mark. So it have a curved border and tipped medial end. So, and if you move the probe, you will find this attached to the transverse process. As you can see here, this is a transverse process, and it looks exactly like the Google mark. Let's have some time to this appearance. So as we said, this is the intercost, the abdominal wall muscles, and this is the extraperitoneal fat, and this one, the transversalis plane that we described before. And then, as you can see, you have a pen. As you can see, this border, as you can see, the muscle border like this. You see, this is the muscle border. So it looks like a Google sign. And as we said, and we agreed that have attachment to the transverse process. So this is a transverse process. To complete the picture, posterior to it will be erectus spinae muscle. Anterior to it will be or medial to it, this one will be the psoas muscle. So this is the vertebral body. This is the transverse process. This is the erectus spinae, psoas minor, serous major, and at the tip, this is the quadratus lumborum muscle. So
2 minutes, Dr. Ahmed.
خلاص أنا تقريبا خلصت.
Okay.
So take care بقى. In this area, this is a paracolic recess. So this it changes with the breathing in this area. So it's better to insert the needle immediately like this. Not from anterior, it breathes either from lateral, or if you can do it from posterior, you can do. So this is a quadratus lumborum in the lateral view. And as I told you, you have to know a lot of criteria, because usually in some patients, is not all criteria is exist. So we have here, it's darker in color than psoas, and also have the Google shape, and attach it to the transverse process. Okay, so I finish this part. I do it, alhamdulillah, I can do it in 1 hour time. And inshallah, I hope if any question at the end, I'll be happy to answer this question. If the question you want me to answer it now, it will be good. If you want me to wait until the end, it will be good also.
Okay, thank you so much, Dr. Ahmed, for your management of time. And okay. I hope that these all blocks will be beneficial to all the anesthetists, especially in recommended cases. I mean the live cases for very old patients that we are afraid to give narcotics, or hemodynamically unstable patients that cannot withstand the general anesthesia for the minor procedures. We have one question from Dr. Mudar from Abu Dhabi. He's asking about, he thanks you first, and he is asking about the cover of the midline, or in your experience with
if you want to do exploration and use the midline, it's very simple. You can do the rectus sheath block vertically, so you can block all the innervation in the rectus sheath. This is a very simple way. If not, and if you want to anesthetize the abdominal structure as well, you can perform before surgery. You can give the paravertebral block. So it
Right.
depends on the case. If the case is just ventral hernia, and so there is a lot of manipulation inside the abdomen, so rectus sheath block bilaterally will be fantastic. But if you have a Weber surgery and you want to pass a catheter, so paravertebral block will give more anesthesia because it will block the abdominal viscera as well, not only the abdominal wall.
His question is about the posterior rectus sheath laterally will be effective for covering the midline.
Of course, yeah, because the nerve coming from lateral to medial. So if you block it at any point lateral to the incision, it will cover the more medial plane. So the nerve coming from lateral to medial. So once you block the nerve at any point in this lateral, it will block, it will give anesthesia to all the structure medial to the nerve. So being the midline is medial to the nerve in the lateral rectus sheath, so it will be covered by rectus block.
Only one question from me. Yes, we saw you, Dr. Ahmed, is spraying alcohol. Is the visualization with alcohol is better than the gel?
It's better, yes. The gel is messy and makes slippery, especially with gloves. It's slippery. And also, I usually inject anyway. I will spray alcohol for the needle injection. So this will cover everything and not messy. And it's very fantastic image. I didn't see any difference between the alcohol and the gel for the last 15 years. However, I didn't publish this. And as you can see, it's very simple and not messy. And usually when you hold a gel with the gloves, it becomes slippery. I cannot fix the probe adequately. So this is far better. So we usually do this in our hospital for a very long time.
Okay, thank you. Thanks so much, Dr. Ahmed. And we hope to see you. We hope to see you at least every month. Thank you.
Thank you so much. Ahmed, thank you so much. That's elegant presentation and workshop. And I'm sure it's going to benefit all my colleagues interested in regional anesthesia. Thank you so much.
Allah يخليك.